Good evening, everyone. It's so great to see so many of you joining us. I invite you to say hello in the chat and let us know that you're here. We welcome you all and thank you so much for joining us this afternoon. My name is Stephanie Paul, and I am the Executive Director of MyFace, and I am pleased to welcome you to our program today. This web education program is designed to inform and educate patients with craniofacial differences, along with their families and caregivers. We also welcome all the healthcare providers who have joined us for this presentation. But please note that continuing education credit is not available for tonight's program. Funding for this program was generously provided by the Louis J. and June E. K. Foundation, with additional support from the Delta Dental Foundation. MyFace has a long history of providing access to comprehensive medical and dental care, along with education and direct patient services, paving the way for better patient outcomes. At the heart of our approach are three pillars of support. First, through our grant funding to top-level organizations across the nation, we deliver quality, comprehensive craniofacial care to ensure that patients receive surgical, dental, psychosocial, speech, nutritional, and other aspects of care in a coordinated fashion. Second, through a range of direct services, MyFace aims to meet the day-to-day needs of the craniofacial community by offering support groups for affected children and adults and parents, distribution of newborn care kits specially designed for babies born with a craniofacial difference, and housing for families traveling to New York City for treatment. Finally, we strive to educate patients, families, and healthcare providers through programs like this Transforming Lives webinar series and raise public awareness about craniofacial differences through our Wonder Project school assemblies and our monthly podcast, My Face, My Story, Voices from the Craniofacial Community, where individuals can share their stories, be seen, and be heard. MyFace is here to bring together the craniofacial community and help transform the lives of children and adults living with facial differences. We believe everyone deserves the chance to thrive and live the best life possible. And now on to our program. We have two presenters and a patient speaker today. Our first presenter is Dr. Pradeep Shetye, a craniofacial orthodontist at the MyFace Center for Craniofacial Care at NYU Langone Health, as well as an associate professor of orthodontic plastic surgery and the director of orthodontics and craniofacial orthodontic fellowship program at NYU. Our second presenter is Dr. Travis Gibson, a clinical assistant professor and part of the faculty of dentistry at the University of British Columbia. He is also the craniofacial orthodontist at British Columbia Children's Hospital in Vancouver, Canada. We will also hear from our patient speaker, Nicholas Zolo. After the presentations, we will open the program for participant questions. And as you think of questions for our speakers, please enter your questions into the chat on your screen during the program. It is now my pleasure to turn the presentation over to Dr. Shetye and Dr. Gibson.
Thank you, Stephanie, for your kind words of introduction. Good evening, everyone, and welcome to this webinar on orthodontic treatment for children born with cleft lip and palate. These are our disclosures, and the learning objectives are follows. We all know that everyone's journey will be different. Each practitioner or the team will have their own protocol in treating a child with cleft lip and palate. We will present our experience and preferences in performing orthodontic treatment. Orthodontic treatment is integrated with surgery when a child is born with clefts. I have divided this treatment into different stages from infancy, preschool, pre-adolescent, early adolescent, and late adolescent. The pink boxes indicate the surgical intervention, and the light blue boxes indicate the orthodontic interventions. For a successful outcome, these have to be integrated closely with the surgical and orthodontic interventions. For simplicity, what we are going to do is divide this presentation into 4 sections. Dr. Gibson will talk about phase 1 and burden of care, whereas I'll talk about presurgical infant orthopedics and phase 2 orthodontic treatment during adolescence. Presurgical infant orthopedics, also known as PSIO, the main goal of PSIO is to reduce the complexity of the cleft. You want to make a wide cleft into a narrow cleft. Research has shown that approximating the lips, nose, and gums can get a better treatment outcome and also leads to less scarring, thereby reducing the number of revision surgeries. If you ask a surgeon which patient will have a better treatment outcome, which patient will be easy for the surgeon to treat, and which patient will need less revision surgery, I'm sure everyone will say the patient on the right. However, these 2 photographs are of the same patient taken after 3 months of PSIO therapy. There are different types of PSIO therapies. The most common is the nasal-alveolar molding appliance, followed by lip taping and the nasal elevator. About 86% of all the cleft centers in US provide some form of treatment. Lip taping is a simple method of PSIO. You can use over-the-counter medical adhesive tapes or tapes made by Dynacleft to approximate the lips and make the cleft narrower. The next is the plates. It could be a passive plate or an active plate. The active plates have to be inserted in the operating room, which is here the Latham appliance. The next appliance is a nasal-alveolar molding appliance, the most popular appliances used in the United States. It has 2 parts, the oral part and the nasal part. The oral part actually changes the shape of the gums, and the nasal stand changes the position and modifies the nasal cartilages. The last appliance is a nasal elevator. It does not have any intraoral component, but a hook that is secured to the forehead. What is the goal of these appliances? The primary goal is to make the cleft narrow. It brings the lips together and thereby allowing a tension-free closure during the surgery and healing process. The second goal for the gums is to bring the gums close. The gums can be separated anywhere between 2 millimeters to 20 millimeters, and bringing the gums closer helps the surgeon to create a tension-free lip closure. In a patient with bilateral cleft lip and palate, the premaxilla is normally displaced significantly, and presurgical infant orthopedics helps to align this gum to the rest part of the face. The most important feature is the nasal anatomy. You will see in patients with unilateral cleft, the nose is significantly deviated, the columella collapsed, and the nasal cartilages are significantly deformed. With PSIO, all this can be corrected, and you can see a significant change in patients with unilateral cleft. In bilateral cleft, in addition to reshaping the nose, the main goal is to elongate the columella and reposition the premaxilla that is displaced because of absence of the muscle. So, not all patients will need PSIO. Patients with incomplete clefts or no nasal deformities or cleft palate only will not need any presurgical infant orthopedics. Infants that have medical condition or need to be operated in the first 2 to 3 months will also not need PSIO. So your provider will actually recommend the right PSIO therapy, whether it's a NAM or just lip taping. When is the best time to start the treatment? The best time to start the treatment is in the first 2 weeks after birth, because this is a time where the nasal cartilages is very plastic and can be easily molded. Timing after 3 months or 4 months, it is going to be difficult for the infant to get used to the molding appliance or any PSIO therapy. If the PSIO therapy is initiated, it should be completed within the 3 to 4 months. Now, Dr. Gibson is going to take over and discuss the need for the alveolar bone graft and orthodontics before and after the procedure.
Thanks, Pradeep. Next, we're going to discuss phase 1 orthodontic treatment, which is treatment performed when you have a mixture of adult and baby teeth, otherwise referred to as the mixed dentition. Sometimes phase 1 treatment is also used to refer to treatment that is incomplete. In other words, we know we're coming back later to do more work. For most patients with clefts, phase 1 orthodontic treatment starts sometime around age 7 to 10 years old, but that can vary depending on your individual needs and situation. When you're getting ready to start phase 1 orthodontic treatment, often people are asked, what's involved? For most patients, the most critical factor here is that we're planning phase 1 orthodontic treatment around alveolar bone grafting, which is a surgical intervention used to treat the area of the cleft that involves your alveolus. That's the part of your mouth where the teeth grow. Common tools we use include expanders and braces, and sometimes we will fix other orthodontic problems as part of phase 1 treatment, such as impacted or ectopic teeth. These are teeth that are growing out of position or are otherwise stuck, as well as bite issues such as an underbite. When you're getting ready to start your phase 1 treatment, I think it's important both for patients and practitioners to develop a clear set of goals together for phase 1 treatment. The first thing that I want to know is what's important to you. If you have, let's say, a very crooked upper front tooth that bothers you, I should probably fix that for you. It's also important that we identify anything that can cause damage if we don't manage it appropriately or that can't be fixed later. Bone grafting quite clearly falls within these categories, as do other orthodontic problems such as a crossbite. That's when some of your upper teeth bite inside the bottom teeth. As well as situations where you have crowded or off-course teeth that might cause damage to other adult teeth if they're left untreated. Equally important, I think it's important to understand what problems are purposely being left for later and not treated as part of. These can include things that might improve over time just on their own, such as crowded lower front teeth when you're in the mixed dentition. Additionally, anything that might be treated more effectively later on, or things that, if we correct it now, have a high chance that we'll still have to correct it again in the future, might be better left to be corrected just once later on in the future. Well, when should phase 1 start? This is a common question that we hear. For most of our patients, particularly those with clefts of their alveolus, phase 1 around your bone grafting surgery, and while this will vary depending on your individual needs as well as your surgeon and center preferences, broadly speaking, the idea is that your bone grafting should be timed so that bone is present within the cleft before any adult teeth grow into that region. If adult teeth grow into the cleft region and there isn't enough bone there, typically those adult teeth cannot be maintained in the long term. And the goal of orthodontic treatment around the bone grafting really fundamentally is to help your surgeon for you. And in some situations, there really is no indication for phase 1 orthodontic treatment. Even in cases such as this one you see here, where the cleft is quite large, the surgeon may not request any changes before they perform their bone grafting surgery for you. In terms of when we should start assessing for this bone grafting and phase 1 orthodontic treatment, this is a tool that we give for practitioners to help time their bone grafting. But broadly speaking, the critical parts here is we'll age 5 and start evaluating what teeth are present around the cleft site, how close are they to growing in, and do they have enough bone to grow in and be healthy and be maintained. And then understanding that, we're going to plan your orthodontic treatment around that bone grafting surgery in collaboration with your surgeon. So we want to make whatever changes they need to give you the best result possible. One of the most common tools that we use and changes that's requested by the surgeon is an expander. An expander is an orthodontic tool used to widen of the upper jaw and the arc of the upper teeth. They come in a bunch of different shapes and designs, but broadly speaking, they all do the same kind of thing. In terms of what we might use them for, there are a couple of different situations. When you look at these photos here, this is from a patient with left unilateral complete cleft lip and palate, and you can see that their upper jaw, although narrow, is generally symmetrical. That's the dotted blue line there. Because the jaw is narrow, some of the upper teeth are biting inside the lower teeth, what we refer to as a cross-odontic problem, both for patients with and without clefts. And just as we can correct this for patients without clefts, so too we can correct this for patients with clefts after they have bone grafting surgery. And so unless something is requested by the surgeon, this is a situation where you might be recommended to go ahead and have your bone grafting without orthodontic intervention and then circle back to the orthodontist later. Conversely, some patients with clefts will have a significant asymmetry or distortion in the shape of the upper jaw and arc of the upper teeth. And those may vary depending on your treatment center and surgeon. Most practitioners request that we change this and make the arch symmetrical before they perform their bone grafting. So, in summary, your expander might be recommended before or after grafting, or not at all, and it might be used either to widen or otherwise change the shape of your upper jaw. It's important that after you have your expander, when it's removed, generally you should have a fixed or glued-in retainer, such as that seen in the pictures here, particularly if you had a cleft that involved the hard palate or the roof. The expansion that was performed tends to be quite unstable and can collapse back if it's not retained. And obviously, we don't want to have to do this twice for you. In addition to expanders, another common tool we use around bone grafting is braces. Braces are simply a tool used to move your teeth. Prior to bone grafting, because there is this area within the tooth-bearing part of your mouth that doesn't have enough bone to support teeth, it's important to not try to straighten teeth around that cleft area. The reason being that if it's into that area where there's not enough bone, now it's compromised and it may not be maintained. As such, when we're moving teeth before bone grafting, it's generally because your surgeon has requested that we make some changes to facilitate their work. As such, because we're trying to not straighten, but simply move teeth in a very specific way, sometimes the braces look a little funny, like they look like they're on crooked or not straight on the teeth. And that's because, again, we're not trying to straighten your teeth here, we're just trying to facilitate your surgeon's work. After you've had your bone graft and the bone has healed, now safely straighten your teeth out with braces treatment. Ideally, if we can perform this when all of your adult teeth have grown in, that can be quite efficient for us to provide that treatment for you. Unfortunately, there are some things that can interfere with that goal of being efficient, such as teeth which are ectopic or impacted, such as the tooth you see circled here in blue on the x-ray. Unfortunately, this is quite common for patients with clefts. Around 1 in 5 kids will have a stuck tooth like this one. Often these teeth have to be some kind of braces component, such as a gold chain, is glued to it, and then it's moved into position with the rest of your teeth. What this translates to is a longer time in braces, simply because there's more tooth movement to be done. correcting one of these teeth can take in excess of 2 years, which is pretty significant when you consider that we're still talking about phase 1 treatment right now. We understand we're going to come back and do more treatment for you later. So we talked a fair bit about things going on with the upper teeth and the upper jaw, expanders, bone grafting, braces, or your bite. So a common bite issue for people who are born with clefts is an underbite. That's when the lower front teeth bite in front of the top teeth. This, in many instances, can be treated with something called a headgear or a reversible headgear. This is a treatment where you have in your mouth an expander or similar appliance which has hooks on either side. You then connect these hooks with elastics to a removable frame worn on your face. The tension from these elastics promotes growth forwards in a more accelerated manner. And the reason that we want to do that is for that most patients with an underbite who were born with a cleft have this underbite because their upper jaw has not grown as much forwards as their lower jaw has. And typically this is related to scar tissue from your previous surgical interventions. There are also alternatives to headgear, such as implantable hooks that you wear elastics to, but broadly speaking, our goal with these is the growth of the upper jaw. And while this effect is quite predictable for patients without clefts, for those born with clefts, unfortunately, it is less predictable, particularly those patients who are born with large or fairly involved clefts. They may have quite a bit of scar tissue from previous surgical repairs, which interferes with the desired effect of this headgear treatment. And rather than the upper jawbone growing forwards, instead, many of these patients experience primarily tooth movement, which doesn't address the underlying cause of the underbite. Furthermore, for these patients still there, we expect that even if you do achieve bite correction, as you grow in the future, the underbite may return and require repeated correction in the future. And as such, headgear can be a bit of a balancing act, both for patients and practitioners. It's important to consider how important is it for you to attempt correction versus limiting your time in treatment and limiting the chances that you have to perform a repeated correction in the future. In summary, I think the most important orthodontic treatment is working together with your orthodontist and treatment team to develop very clear goals for what you want to achieve. Next, Pradeep is going to discuss phase 2 orthodontic treatment in adolescents. Thank you.
Thanks, Travis. Thanks, Travis. I'm going to talk about orthodontic treatment during adolescence. For ease and understanding, I've divided these sections into two parts: early adolescence between age 10 to 15 years and late adolescent between age 15 to 20. The reason the treatment is divided into these two parts is during early adolescence, there is rapid growth of the upper and lower jaw, and during late adolescence, this growth slows down. So there are two factors to consider when orthodontic treatment is recommended. A child that has a favorable jaw growth, you can perform a comprehensive orthodontic treatment, whereas a child who has an unfavorable jaw growth, we should avoid doing any comprehensive treatment, because if treatment is performed and the child continues to have the unfavorable growth, all the correction will be undone. So let's look at the chart flow of patient that has a favorable growth pattern or an unfavorable growth pattern. When I mean favorable growth pattern is the patient doesn't have an underbite or the underbite is mild. If someone has a mild underbite, then you can do a comprehensive orthodontic treatment and align the top and the bottom teeth, and that will be the end of the treatment. The patient that have an unfavorable jaw growth, that means the upper jaw is growing slower than the lower jaw, and the underbite is progressively becoming worse over time. In those patients, a limited treatment is offered. Only treatment on the top jaw where the problem arises, and as to be done in a shorter period of time. So we're going to show you some examples of patients with having a favorable jaw growth and those having unfavorable jaw growth. Take an example of this child had a unilateral cleft of the right side. There was a missing lateral incisor. The canine was in the position of the lateral incisor. The patient underwent a comprehensive treatment, braces on the top and the bottom jaw, and this was the end result. And you can see she had a beautiful smile at the end of the treatment. And when we followed her up to a skeletal maturity, the bite was stable. She did not need any further orthodontic treatment. Next, we're going to see another patient that also had a favorable growth pattern, had an underbite that was mild, but two teeth were peck-shaped. She underwent a comprehensive orthodontic treatment, teeth position were corrected, and then the patient was referred to a dentist for cosmetic restoration of smaller teeth. Let's look at an example of a patient that had mild underbite. The patient used a headgear, as Travis shown in his presentation, the effect of headgear. Not all patients' treatment is stable, and this particular patient had a favorable growth with the headgear. We opened up a space for the missing tooth, and then patient was referred for an implant placement, and you can see that his bite was stable. Patients that have unfavorable growth of the upper jaw and lower jaw, we only address this where there is a problem, especially in this patient. You can see there's a significant crowding of the top teeth. The lower teeth were crowded, and it doesn't make sense to put the braces on top and bottom where you would going to increase the underbite. The prudent thing to do in this patient is only address the top problem, because this patient will need treatment at skeletal maturity, most likely jaw advancement surgery. Let's look at next patient that had an underbite. There was no reason to do any orthodontic treatment in the lower jaw because all the teeth had developed properly, but the two canines were impacted on top. So the treatment for him was only upper jaw treatment to bring those impacted canines into the arch. Now, late adolescence is the time where the skeletal growth slows down. There are various ways to assess the cessation of the growth. One is taking a hand-raised radiograph and looking at the radial growth plate. And the second is taking two heads x-rays 6 months apart to make sure that the lower jaw growth is complete. At this time point, we collect data and come up with the treatment plan options. And there are several treatment plan options in these stages. One, if the child has only a mild jaw discrepancy, then this child can be treated with orthodontics alone. If the child has moderate to severe jaw discrepancy, there are three treatment options: do nothing, upper jaw surgery only, or upper and lower jaw surgery. Let's look at some examples in these four different categories. This is a patient that had a mild skeletal jaw discrepancy. There was a missing tooth in the area of the cleft. The orthodontics involved correcting her crossbite or underbite and opening space for the missing lateral incisor. And you can see this child had good overjet and overbite. Next patient you're going to see is regarding the jaw surgery. If the child elects to undergo jaw surgery, there is going to be pre-surgical orthodontic treatment followed by jaw surgery, and the braces will stay on anywhere between 6 to 12 months after the jaw surgery. About 6 months after the jaw surgery, there's options of doing rhinoplasty or lip and scar revision if needed. Again, not all patients will need this, but the child or the patient can choose either to have this procedure or not to have the procedure. The cosmetic dentistry is done after lip and scar revision surgery. So this is a patient that appears to have a mild underbite. The goal of orthodontic treatment is to increase the discrepancy to optimize the position of the jaw. So this is called pre-surgical orthodontic decompensation. And you can see for a short period of time, the underbite is increased, and after surgery, the jaw is positioned correctly. Let's look at the changes that this surgery accomplished for this particular patient. The lips were now lined up because the underbite has been corrected. The facial convexity that is seen around the nose has been corrected, and the face looks much more convex. And patient also had the nose surgery. If nose surgery is indicated, the best time to do the nose surgery is after the jaw surgery. In some situation, the goal of orthodontic treatment is to reduce the underbite so that the surgeon can optimize the position of the jaw. This patient had undergone the upper and lower braces, and you can see the underbite was significantly increased. So the goal was here to remove a tooth on the lower jaw, reduce the discrepancy between the upper and lower jaw, and then advance the upper jaw to optimize the position to the lower jaw. And you can see a significant change in the facial profile. There are some instances that the jaw needs to be moved in pieces. This particular patient had no history of bone graft, and the Le Fort 1 was done, and the space was reduced, and bone graft was performed at the time of Le Fort 1 surgery. Next is, when do you do a lower jaw surgery and the upper jaw surgery at the same time? The main reason to do the upper and lower jaw surgery is patients who have an asymmetric upper and lower jaw position. You can see that the center line of the top and the bottom is significantly deviated, and this particular patient underwent both the upper jaw and the lower jaw surgery to align the jaw. The second reason to do the upper and lower jaw, if the lower jaw is anatomically bigger than the normal, in that situation, you would also perform the top jaw and the bottom jaw surgery. So let's look at this from the frontal view. You can see the chin is significantly deviated. The center lines don't match up. And after surgery, both the center lines and the chin position is corrected. So orthodontic treatment is a collaboration within your Cleft team. You need to have your surgeon, the speech and language therapist, your social worker, your nutrition, and all the members involved in the decision-making process. Orthodontic treatment is provided in short phases, timed of different stages of growth. When we take the braces off during these different stages, retainers must be worn to maintain that correction. Otherwise, we'll have to repeat the procedure that was done previously. During adolescence, especially during the orthodontic surgical planning and the soft tissue revision, we have to have the adolescent patients taking part in the decision-making process. And the next, Dr. Travis is going to focus on how to reduce the burden of care.
Thanks, Pradeep. So we have discussed a bunch of different orthodontic and orthodontic associated treatments spanning from birth to adulthood. And you could look at that and understandably say, you know, it sounds like a lot. And I think you'd be right. There is research on this topic that's shown that for a patient with a complete cleft lip and palate, the treatment time can extend from 41 to 141 months in treatment. I mean, that's nearly 12 years of orthodontic treatment. When we add of their treatment, like when they're completed their orthodontic and their jaw surgical treatment, how they feel about the outcomes of treatment, patients born with clefts are significantly less likely to feel that their treatment journey in orthodontics improved their overall quality of life as compared to their non-cleft peers who had similar orthodontic and surgical treatments. And I think that, you know, a big component of that is just the length of time in treatment that many patients can experience. And so I think it's important for both, you know, patients, families, and especially to this, and try to limit the amount of time in treatment wherever possible. With this in mind, how can we best work together to make your orthodontic journey as good as it can possibly be? Should come as no surprise. I think goal setting is important at every stage of your treatment. Having a good understanding of what you and your care team are hoping to accomplish is a great place to start. And then advocating for yourself as a patient or for your child, for parents in the audience, to make sure that their treatment maintains its orientation to those agreed upon goals. With regards to orthodontist, about how to choose the right orthodontist, and the right orthodontist is going to vary from person to person. For you, you may wish to see the orthodontist associated with your Cleft team, whereas other families, it may be important to find an orthodontist within their community that they can trust, so that they don't have to travel a long distance to see their Cleft team. If you are looking for an orthodontist in your community, I'd suggest reaching out to your Cleft team and your Cleft team orthodontist. Many of us keep essentially lists of people that we collaborate with frequently in the community, who we trust their expert patients. Once you're in treatment, it's important to take care of your orthodontic appliances, keep your teeth clean so that they move efficiently and that you don't develop cavities. And of course, don't break your orthodontic appliances. And then critically, as Pradeep mentioned, when you remove your orthodontic appliances, make sure you wear your retainers diligently so that you don't have to repeat correction that you've already achieved. With all of this together, I hope that you can have the best orthodontic journey possible. Next, it's my pleasure to pass this over to Nicholas Zolo, who's going to talk to us about his treatment journey from the view. Everybody, welcome, Nicholas.
Hi, everyone. I'm Nicholas. So a little bit about me. I was born in China with a cleft lip and cleft palate, and I've also been told, and we have photos somewhere, that I was born without a nose. So in China, they did some reconstructive surgery. They built me a nose, and that was my very first cleft lip and palate surgery. I don't remember it. I was quite young, probably a few months, I'm guessing, based on what these doctors have been saying about the process. But at the age of 2, I was adopted into an Italian family, and I moved to New York City, and that's where I met my lovely team, including Pradeep Shete. So the earliest surgery I can remember was actually the bone graft surgery I underwent in the winter of 2009 when I was only 5. But I do remember the recovery. I had a lot of trouble walking, eating, and definitely speaking. I had to do a lot of speech therapy, both in preschool and preschool and elementary school. So that was definitely something that I remember quite vividly. I had also started to wear braces on my baby teeth to prepare them and also to make sure that they stayed in place. And I also had to wear headgear, another one of the things that they had both mentioned, and that was to keep my teeth aligned and straightened. And I believe I also wore it to try and pull the teeth forward, but I'm not entirely sure. So once my adult teeth fully came in, I wore braces once again from 2017 to 2019 to realign my adult teeth and pull down a tooth that was impacted in my upper palate. So it was quite far back, I believe. So I'd have like a mini surgery for that where they would attach a chain and it would pull into the side of my mouth. So that way my teeth would all be there and aligned and ready for surgery. So perhaps the biggest surgery I had was the jaw realignment surgery I had in 2022. I wore braces for a third time, roughly 6 months before the surgery in preparation. I also had preoperative meetings with my surgeon, a speech pathologist, a dietitian, and a psychologist to help me and my mother through the process. It's quite it's a long process. It's also can be very mentally draining. I'll say that. It's definitely something that it's nice to be well prepared for. It's nice to have other people within the MyFace community or even any cleft of cleft palate community, just talking to them, getting to know their experience, hearing what they went through. It helps you prepare for what's to come ahead. I know for me, I didn't entirely do everything maybe that I could have done, like preparing myself mentally, but I do think that at the end, it's worth it to talk to people, to reach out, to connect with people. But this was definitely like the hardest journey for me. My recovery period was about a month and a half, and this was right before my freshman year of college. So going into college, I couldn't really do a lot of like sports because I was still healing. I had to eat liquid food for 2 to 3 weeks, which I absolutely hated. I honestly I was miserable, but eventually I kind of got over it. Because then I started going to soft foods, and one of my favorite foods since I was a child, since my very uh, first surgery that I remember, my bone graft. I love cornbread and milk. It sounds really weird, but it's my favorite food uh, to eat when I have to have soft foods. Um, so both during my pre-ops and post-ops, I had been offered a rhinoplasty, as was mentioned earlier, for my nose, but I decided not to do that because I believe that it kind of would take away a little bit of my uniqueness. I think something that maybe a few of us, if not all of us, might struggle with is our image going into surgeries, going out of surgeries. You know, I would think we're all generally self-conscious and self-aware. We all see how we look. You know, we might see people staring at us. We might hear people making comments, and I think that's just kind of uh, a side effect overall of what we go through. But that just makes us better, builds us up because we learn how to deal with our differences early on, and that kind of gives us the advantage in the end. So some highs and lows. Obviously, surgery was difficult. As somebody who hates needles, I did not like anesthesia. Eating tubes and the syringes were unpleasant. I could not eat some of my favorite foods like pizza. I love pizza. Could not eat that after jaw surgery, especially with the crust. Like I mentioned earlier, I could not play sports, and I do love sports. Despite everything, the recoveries and accompanying social isolation did help me grow. Like I mentioned, it gave me time to think, gave me time to reflect. I would ask myself, why do people stare? Why do people look? Why do people ask these questions? And to me, it all came down to they're curious, they want to know more, or they just don't understand what it means to have cleft lip, cleft palate, and to go through what we go through. And I think something else is that I learned that not everyone is staring. Some people are in their own world. Some people are looking maybe behind me or behind you. So you just got to keep your head up. You got to push through. It can be tough at points. I know that for certain. But at the end, I think if you just brave it out and you push through, you'll do perfectly fine. The questions and comments will definitely stop at some point. For me, for the most part, they've stopped and they're not as hostile as they used to be. Now it's more people are curious about what it is rather than saying like, "Oh, what happened to your face? Were you on a fire? Did you get burned?" All of that kind of stuff. But as I mentioned earlier about the rhinoplasty, it was a tough decision. I never liked my nose. I never really liked my face. It was something I was very self-conscious and self-aware about. But at the end, I did realize it's what makes me unique. I talked to a lot of people about this. My mom was definitely a big person of saying, like, it makes you unique, and I love her for that. And having that surgery done, to me, would feel like it takes my physical uniqueness away. And I've come so far to be so unique that I think having the rhinoplasty for me personally would just make me feel like I've just kind of went back on my word and kind of just said, "Oh, I'd rather just be a normal person rather than being someone so unique with so much personality." Physically, I'd look like everyone else, but I don't really want it to look like that anymore. Thank you.
Thank you so much, Nicholas. I'm going to say you are not only unique, but you are extraordinary. Thank you so much for sharing your story. I want to thank Dr. Chettier and Dr. Gibson for their incredible presentations. It's now the exciting time for questions and answers. And we have a number of people on this call today coming from Singapore, Mexico, and all over the United States. So for those of you who do have questions, please go ahead and put in that into the live chat on your Facebook or your YouTube stream. We do ask that you ask questions general in nature so that our wonderful speakers can answer those questions general in nature. So I'm going to kick it off with a question for Dr. Chettier, if I may, from Lauren. And the question is, we live over an hour from our craniofacial center. How do we go about finding a local orthodontist who has experience treating children with cleft lip and palate? If possible, we'd rather not commute back and forth to the craniofacial center for all of our children's orthodontic care. Dr. Chettier, how do we cope with that difficult situation?
That's an excellent question. And Dr. Gibson really answered that question when he presented about how to find the right orthodontist. One of the resources is finding either a team closer to their hometown and see who's an orthodontist that's working with the team. The second is find out an orthodontist who is in private practice but have had worked at a cleft center in the past and has some cleft experience. The other way to do it is talk to your main cleft team and get a recommendation from your parent cleft team.
Terrific. Thank you, Dr. Chettier. A question for Dr. Gibson coming from Shelley. And the question is, who drives the timing of bone graft surgery, the orthodontist or the surgeon? What if the surgeon wants to prep sooner and the orthodontist wants to wait? Who then decides?
Cool. Thanks, Shelley. Nice to hear from you. Ideally, together, the goals are the same, right? We want to see bone, where teeth are going to grow before they grow in. Sometimes there are practical considerations. The X-rays show that a tooth is going to grow in soon, at maybe age 5, and we have to have a realistic conversation about what kind of orthodontic treatment can a 5-year-old tolerate, which honestly is not always a lot. And so sometimes it's a balancing act of how soon do we want the bone graft to happen and how much orthodontic treatment do we want to do surgeon's work. And hopefully your orthodontist and your surgeon can discuss that together, weigh the pros and cons of waiting versus acting sooner, perhaps without the orthodontic preparation that they might preferably desire.
Okay, thank you. So let's follow that up with what is the right age to do, and either Dr. Gibson or Dr. Chettier, what is the right age to do the secondary alveolar bone grafting, and what sort of success rates would you advise your patients to expect?
Travis, you want to go because you spoke on bone grafts?
Sure, why not? Earlier in the presentation, we had a little flowchart up, which outlines kind of our approach to when to do alveolar bone grafting. It could range anywhere from age 5 up to perhaps age 9 or 10, and in some instances, we're even talking about doing bone grafting in adults around jaw surgery, such as one of the cases that Dr. Chettier showed us. The success rate is generally fairly high. It's above 80 to 90%, with variations depending on material used, orthodontic preparation, individual situation, all kinds of details that are probably better addressed surgeon than your orthodontist.
Thank you, Dr. Gibson. Nicholas, let's dig a little bit more into the decision you made about not having the rhinoplasty or having your nose changed. We have someone who's written in who has not quite reached that level of self-acceptance that you have. What advice do you have for those folks who haven't really learned to embrace themselves quite yet?
That's a great question. I think I think it's all down to preference and how you view yourself. I mean, personally, I've met a lot of people who don't really accept themselves the way they are, and they are well in their 50s. But I've also met a lot of kids who are, maybe 13, 14. They've already accepted who they are. So I think it depends on where you are in your life for you to really be able to make that decision. And it is a incredibly important decision. It's life changing. So I think uh, the best thing that I can say for that is talk to people, anybody, to parents, to loved ones. Again, surgeons definitely, to your health providers, and see what they say. I mean, I've had a lot of people saying to me like, "Oh, you don't need it. Your nose looks fine." I've also had other people say, uh, you know, it could boost your self-esteem. I've had some people even say like, uh, "Your nose is different, but that's fine the way it is." And I think when I hear people say that my nose looks fine or that my face looks fine the way it is, then that really kind of says to me like, they may notice your face, but it's a good thing because they're saying it's fine, it looks fine, whether it's out of comfort or just because they think it's a nice thing to say. To me, it doesn't matter at the end of the day because I know in my heart that my face looks fine, that my nose is fine, that my nose does what it needs to do. It does its job. It helps me breathe, helps me smell, gets all the stuff out. So I think at the end of the day, talk to people, honestly. If you're not at the stage of self acceptance yet, that's perfectly fine. I think everyone is at a different stage in life when it comes to self acceptance. So, not having the rhinoplasty uh, just means that you've decided that you accept how you are. And having the rhinoplasty just means that maybe you just wanted that little extra boost to help you feel better about yourself. And that's perfectly fine, honestly. However you get your pleasure out of life, whatever you need to do to help you feel better, that's for your own decision, and that's just how you'll deal with it.
Thank you, Nicholas. You are incredible. If you could go back to young Nicholas and give yourself a piece of advice, what would it be?
Um, the funny part, the funny answer would be wear your retainer more often. But the serious answer would probably be use your resources. I don't think I talked to my mom mostly after appointments about what we're going through, but I never fully talked to her like outside of it. I never just said, "Hey, mom, like let's talk about Cleft with Cleft Palate." I mean, the thing that I talked to her the most about was me when I was in China and the photos that she had of me. But I never actually sat down with her and said, "Hey, I'm thinking about when I had my." I never said to her, "Hey, I'm thinking about my bone graft and how terrible that was." I never sat down and talked to her about that. So my advice to my past self would be just talk about it, help you get over it. I think it probably would have helped me be less nervous for other surgeries I had. I mean, I remember I had a breakdown when I was having the uh, upper part of my palate removed so that they could pull my tooth in. Um, I think if I talked more about it and the procedure coming up, I probably wouldn't have had a breakdown. But I had plenty of time to talk about my jaw alignment surgery, and when I walked into that hospital, I was cheery. I was ready to go. I was like, let's get this done. Let's get this over with. So I think just talk about it. If I could say to my younger self, I'd just say talk.
Great. I love that. And wear your retainer. Um, a question for Dr. Chettier. How early on can you determine if a child may need jaw surgery in their adolescence? Is this something that can be predicted during phase 1? Also, who performs the jaw surgery? The surgeon?
Yeah, to answer the last part of the question is who performs the jaw surgery. The jaw surgery is performed by a surgeon. It could be a plastic surgeon, the oral maxillofacial surgeon, or craniofacial surgeon would usually do the jaw surgery. How soon you can predict? It's very hard to predict because jaw growth is multifactorial. It depends upon the genetic potential, the scar tissue on the palate, inherent genetic growth pattern. If the child has inherited a larger lower jaw, and then the cleft upper jaw, or vice versa. So I would say that you have, during the phase one, you would see some, if the underbite is significant at that time, then yes, 100% the child will need jaw surgery. But as you grow through the early adolescent, and is the time where you'll see that the upper jaw and lower jaw don't grow at the same rate, right? So any intervention you do, as Dr. Gibson pointed out, it will be undone or uncorrected because of the differential growth of the upper jaw and lower jaw. So as an orthodontist, we constantly monitor the growth by taking radiographs too, or clinical evaluation, and we can, alert the family. We do see an unfavorable jaw growth pattern. It's better to wait for definitive treatment till the skeletal growth is complete, and then we can make a decision. Either we're going to camouflage this by just removing teeth and adjusting the teeth, or adjusting the position of the teeth, or undergo jaw surgery. Dr. Gibson, you have to add anything?
So, Dr. Shetty, sorry, a question. You talked about interdisciplinary care, and one of the things I'm curious about is really how social emotional issues wrap into that, and how important is that as part of treatment?
Yeah. So what I do is, when I finish with my phase 2 treatment at around 12, when all the adult teeth in, I put the patient into what's called observe category. So I see this patient on an annual basis from 12 onwards. And as soon as I see that they are close to maturity or almost mature, depending upon their parents' interest, the patient's interest, we would then obtain, the diagnostic records if they say, yes, we want to have the surgery. Some patients will tell me, I don't care, I don't want the surgery, I'm going to college, I will consider this when I finish my college or before my job. And there are certain patients that we don't offer anything. If the patient has shown interest in undergoing jaw surgery, I will collect the diagnostic records and then bring this patient to the conference where the surgeon is going to evaluate, the speech person is going to evaluate, the psychosocial person is evaluating, the dietitian, nutrition is evaluating. And then we present it whether the child or the patient is ready to this the surgery. We also talk about all the consequences, right? Sometimes the patient can develop what's called a VPI. The speech can be altered after surgery. So all these risks are discussed ahead of time. And once they say, all right, fine, I would undergo, then only I will put the braces on in preparation for surgery. So all that work is done before even putting braces on the patient, because the braces will, as I said earlier, the braces will make the bite worse. And if you realize that we made the bite worse and patient says, oh, I don't want surgery now we have put the patient in a worse position than when you started with. So evaluation, those psychosocial evaluation or the team evaluation is very important before committing to the surgery.
Terrific, thank you. We have a question that says, hi, I'm an international dentist, and thank you, Nicholas, for your brave story. Well done. The question is, not everybody wishes to live with a surgery scar. What interventions do you recommend for a scar? And Dr. Gibson, can you answer that question?
Ooh, not really, to be honest. As an orthodontist, my expertise is in moving teeth around. Scar protocols is, thanks, Pradeep.
Yeah. There are a couple of options. I will say for female patients, it could be the makeup that can easily cover the scar tissue. For male patients, there are typically two options. One is tattooing, can actually blend the scar. And the second option is also doing hair transplant. You can find expertise of a surgeon who could actually take hair and place it in the scar. Even if the patient doesn't want to grow a mustache, that those hair follicles can blend the scar very nicely.
Okay, thank you. Let's see, we have time for a couple more questions here. And maybe this one, Dr. Sheche, what is the current research showing for alveolar grafting techniques, hip bone versus cadaver bones?
I think I think it's a surgical preference. I think in good hands, both the technique can work very nicely. But I don't personally have not evaluated the long-term outcomes of hip bones versus the cadaver bone.
Okay. One question for Dr. Gibson. What are your thoughts on canine substitution rather than dental implant for missing teeth on in a cleft site?
This is from Dr. Canalatos. Love your Instagram, Jessica. Nice to hear from you. This is going to vary by, honestly, I think region a lot. So up here where I'm at in Canada, orthodontic treatment for patients with clefts is covered by our public medical insurance. What is not covered is tooth replacement. And so very commonly what we're looking at doing is trying to find ways to achieve an excellent while still avoiding significant out-of-pocket expenses for families. And so I do a lot of canine substitution. I will bend over backwards to slide teeth around so that there are no gaps where teeth are missing if I can do it. And that's a very practical insurance-based consideration for me. Pradeep probably has a different approach because he works in a different environment.
Yeah, as I said, I prefer to open space if there is a space. But as I showed you, one patient that I showed you was closing the space because the canine had already was positioned in the lateral incisor. And if there is a midline deviation of the upper teeth and the bottom teeth, and you want to get the midline centered, then yes, I would open space and then refer the patient either to replace that tooth by prosthetic or by implant.
Thank you. Okay, the last question, very important question. We're saving it for Nicholas. And the question is, do you have any interest in going into dentistry or the medical profession after your very long journey?
So when I was younger, I thought a lot about it. Working with my lovely team at NYU, it was definitely a consideration. If I did go into it, I would have I would say probably the easiest time talking to patients about it because I myself had went through it. I could tell them, how it's gonna be. Like somebody mentioned here, I've been very honest about it. I would obviously be honest with them about it. However, I don't see it in my personal future. Currently, I'm studying business management and finance, but I still do want to be involved with this community. I think it's a great community. When I was asked to do this webinar, I said yes in a heartbeat because I like to share my story. I like other people to know my story because I think it's comforting to know that somebody else went through this. But unfortunately, I don't think I will go into dentistry.
Okay, well then I can maybe have you come in and work at MyFace because we do a lot of business at MyFace, and that would be a great place for you to work one day. Well, I have to say thank you, Nicholas, Dr. Gibson, Dr. Shetye. This was an incredible presentation, and I hope everyone enjoyed the program. I do apologize that we didn't get to all of the questions, but if you do have additional questions, please send those to info@myface.org. Because craniofacial differences can impact the body and spirit so significantly, MyFace provides important direct services such as access to a variety of patient and family support groups, which take place virtually, podcasts, and workshops. These programs offer guidance, resources, and a supportive environment for all who participate. MyFace also hosts live events that seek to bring our community together to empower the spirit and build strength, and let families across the country know that they are not alone. For more information about our programs and services, please visit us at myface.org. To let you know, the next MyFace, My Story podcast episode will drop on November 15th. It's entitled Hiding Behind a Mask, a Conversation with Mary Avella. To learn more, visit myface.org/my story, and you can view the MyFace My Story podcast on all podcast platforms plus YouTube. I'd also like to draw your attention to one of our programs in particular, which is our virtual support groups. MyFace offers a series of online support groups for the craniofacial community, including support groups for parents, adults, adolescents age 14 to 18, and prenatal infant parent support groups. These sessions take place either once or twice per month and are either therapist or peer-led. So for more information, please visit our website at myface.org/online-groups. We invite you to join us in person for MyFace's magical holiday celebration, which will take place at the Church of the Holy Apostles in New York City on Friday, December 15th. Additional information about this event will be posted on our website in the coming weeks. And coming early in 2024, we will have our next installment of our Transforming Lives webinar series titled Support That Helps Families Impacted by Cleft Lip and Palate and Other Craniofacial Conditions to Thrive. This program will feature Dr. Meredith Albert and Dr. Janine Rosenberg. Again, for further information, visit our website at myface.org. At MyFace, we strive to provide the most helpful and informative resources. To help us do so, we ask that you take a few moments to complete our brief survey by using the QR code provided or visiting myface.org/orthodontic survey and let us know your thoughts. We have also provided this information in the reminder email that will be sent to you after this program. Again, I thank you so much for sharing your time with us today and have a wonderful evening.